This is First Pediatrics. Hello everyone, and welcome back to First Pediatrics. Today, we have another special episode for you. I'm going to let you listen in and join me for a lecture I gave a few months ago for a recurring lecture series called Friday Morning Report. There are residents, medical students, and faculty in the audience today, and they gave me permission to record and share this. Laura, one of the former chief residents of the Michigan residency program that you might remember from the new cancer diagnosis episode, I'll let her introduce things for us.
All right, good morning everyone. Thanks so much for joining us on Zoom and in the room. You might notice that the conference room looks set up a little bit differently this morning. That is highly intentional. We have Dr. Chris Demas here who is going to be giving a unique style Friday morning report, and it's going to be like a live recording of a podcast. Something is happening in the chat. What is that? Woo, Chris! Yes,
So supportive.
I know.
Now, even though this style episode is a little different, I hope that you'll be able to think through the case and how you might answer the questions while hearing from some of the residents in the room. And realize this episode was recorded during the workday, so expect the unexpected.
Yeah. And I also realize pagers and phones might go off. It's like a natural environment in what we're dealing with, so don't worry about that. Do you guys have any patients that you're actually taking care of right now?
That's fine.
Okay.
Let's introduce this one like the others, and I'll circle back with you at the end of the episode.
Hey everyone, my name's Chris.
And we are Michigan Pediatrics.
Go Blue. Thanks, Judah. And welcome to the first live recording of First Pediatrics. This episode might sound a little different since I'm recording this episode as part of the Michigan Pediatric Residency Friday Morning Conference. I do realize that I'm navigating through uncharted waters, and I hope this is an enjoyable experience for those in person and anyone who's listening. In this episode, we'll be talking about a case involving pediatric chest pain. So chest pain is truly something that we see quite often in pediatric medicine, both in the outpatient setting and in the hospital. And whether you're in the emergency department, cross-covering patients on the night service, on the inpatient side, it can be sort of intimidating, and having a nice way of approaching chest pain can be very helpful. So obviously, it's stressful for us, but it's also stressful for families and patients. So having a way to approach this to provide comfort is also appropriate. So my goal is to give you the tools on how to approach pediatric chest pain, how not to miss the important causes of cardiac discomfort, understand the key history and tests to help narrow your differential, and hopefully help you feel more confident for the next patient you care for with chest pain. So just to set the scene for those that are listening, we have our pediatric residency conference room. We have people in the back. Go ahead and say hello, everyone. Hello. Yeah, we got the people in the back. Then we have the people who are close up to the mic. So we have Judah Frisch, who's a third-year pediatric resident. You want to go ahead and say hello?
Hi.
And then we have Keats Ewing. Go ahead and say hello, Keats. And he's
hello, Keats.
He's one of our third-year pediatric residents as well.
And
they were brave enough to come sit up front. I know Keats didn't necessarily know what he was getting into.
Nope.
Nope. So you guys ready to get started with the case?
Sounds great.
Sure, why not? Let's do this.
All right. So you're seeing Lindsay. She's a 20-year-old female, and she's presenting in the emergency department with 2 days of chest pain. So what do you want to know on the history? And I look out into the audience right now. What sort of things are you guys thinking about when you have chest pain? Any particular questions you have?
When did it start?
Great. So when did it start? It started about 2 days ago. It's been happening on and off. The first time it happened, she was driving at the time, and it's just been happening a little bit more frequently, which is making her come to the ER today.
What does it feel like?
What does it feel like? So it's like a central chest pain. She's describing it as about an 8 out of 10, and she's having like a little bit of difficulty breathing during these episodes and some tingling in her left arm.
Anything seem to make it better? Anything seem to make it worse?
Sure. So there's really nothing that seems to make it better or worse. I guess in particular, I'll mention that she's not a big person that exercises, but when she walks around, it doesn't seem to make it worse. It just happens spontaneously, and she doesn't really seem to have much control, it feels, over the pain.
Is she having anything else with the chest pain? Is it just chest pain, or is there like fainting? Is there lightheadedness, dizziness?
Great. So great associated symptoms you want to think about. So there's been no fainting, no prior history of fainting, and she's not currently feeling dizzy or anything like that.
Has she ever had anything like this before?
This is truly the first time that she's experiencing this type of chest pain and discomfort.
Is it tender to the touch?
Great. So think about, is it reproducible? Like, she pressed on her chest and she says, no, that's really not making it worse.
Is the 8 out of 10 right now, or is that at its worst that she's had it?
So that was at its worst as well.
And what is it currently right now?
Right now, she would say it's probably like a 3 out of 10, but it sort of fluctuates, as mentioned. So I think this is a great place to start. I'm just going to summarize a few other things. Maybe you haven't mentioned them, but so she's had this 2 days of pain. It's intermittent. It's sharp pressure, center of her chest with associated tingling. It's not reproducible. It's not worsened with exercise or deep breathing. Symptoms don't seem to align with eating. That's one thing that we didn't ask about, but something that I typically do like to ask as well. She hasn't had any trauma, no recent injuries. She also hasn't mentioned any fever, sick symptoms, those sorts of things. And I asked her in particular, did it wake you up from sleep? She said no. So when I am approaching a child with chest pain, I try to think, did I ask questions related to what I would say is like red flag symptoms? And does anything up here stand out to anyone? Does this sound like a red flag symptoms? If not, maybe do you have any red flag symptoms that you typically ask about or are negative up here?
Exertional.
So thinking about exertional chest pain, and fortunately she doesn't have that. I guess I think about with rest or exercise, if it's with exercise, you're thinking about it has to do with demand. You might have some sort of ischemic problem going on. If you're exercising, it's making it worse. Judah, you asked about syncope. Why did you ask about syncope?
I mean, I'd be worried more about that's like I think can be a red flag syndrome depending on what you're else experiencing with it. Are you having like vital sign instability? You know, like so like you're hypotensive and you're fainting, or is it just more like vasovagal, kind of like thing?
Yeah.
But like so. In itself, it's not a red flag, but it's to make you then think about, are there other symptoms there that she's having?
Sure. To help differentiate, I'm going to have people raise their hand. So it's either with a prodrome or without a prodrome is like the ways that I think about it. So would you be more worried if someone had a prodrome, so like maybe they felt dizzy, they like felt warm, and then they fainted, or they just like fainted? So like with prodrome, hands up, without a prodrome. So everyone in the room is raising their hand without a prodrome. Mm-hmm. I think I would say, like, for sure, you think about hypertrophic cardiomyopathy, so things that could cause you to just immediately lose your ability to perfuse, and fainting without a prodrome. Other things with prodrome, certainly vasovagal is the big one that I think about. Then the other thing that I ask about, too, is, like, quick on and off is one other thing I think about. Maybe Keats. If I say like on and off and it goes away completely between episodes, is there anything that you might be thinking about with something like that?
Or referencing like arrhythmogenic in some way, shape, or form.
Yeah.
Kind of a sudden onset going into an accessory pathway circuit thing, and
Great.
It just
Great.
comes on real quick.
So also thinking
Mr.
if
Future Cards person over here.
Chest pain podcast episode. I'm terrified right now.
I'm sorry, Keith.
They've already accepted me. They can't say no. Okay?
But you're absolutely right, Keith, right? So if it's a quick on and off, you're thinking about arrhythmias a bit more. And that's also not something that we're hearing. So I think overall, we're maybe identifying that she doesn't have like these high risks that we hear, but she's really concerned about it. So we want to be thoughtful. We want to make sure we ask a good history. So when we get to something like a past medical history, there are so many things we can ask families. I have like some pearls I'm going to share with you about, things that you might want to ask a family that presents, or a patient that presents with chest pain. But can anyone think of, questions you might want to ask, or look in their past medical history in particular?
Birth control.
Okay. So what are you thinking about with that?
Like a clot risk.
Great. So you're thinking about, what was mentioned was birth control, estrogen-containing products can increase your chances of having something like a PE and chest pain. Great.
Any history of sickle cell disease?
Great. So thinking about other forms of chest pain, whether it's hematologic even, and sickling of cells causing you to have acute chest, like that would be something you would not want to miss, and it would lead you down a whole different way. Any other things you guys maybe are thinking about, generally speaking?
I mean, I would think about like autoimmune diseases that kind of along the similar lines of that, the clotting stuff that puts you at risk for having sort of a hypercoagulable state. So
Sure.
autoimmune diseases, like cancers, like those things kind of like make you
absolutely.
more risk for those clots. And having that PE that you mentioned, child and chest pain.
On that same line, from an oncologic standpoint, if they've ever had chest radiation before, because that increases their risk of coronary disease.
Great. So any sort of injury to the coronaries that can cause abnormal healing and things like that.
Kawasaki's as well, which is where I assume you're going.
So you're thinking about Kawasaki's.
Yeah.
And actually, one thing just to point out is a lot of people might not know that they had Kawasaki. Like, I'm not saying a lot of people, but some people might not know. So even asking, have you ever had a fever that lasted more than 5 days, if they're coming in with chest pain, because they might be at a higher risk of Kawasaki, aneurysm, and ultimately that can affect the flow in the heart, and ischemia then would be at the highest of your differential potentially. I'm just going to mention a few things before I go into the history too. So connective tissue disorders, anything that you might think about with those?
Like lupus?
Wait, what are you thinking about with that?
Like a pericarditis?
Okay, sure. So that's a great one. Absolutely. I was thinking with connective tissue disorders, thinking of Ehlers-Danlos or Marfan syndrome. Exactly. So all of those things can increase your risk of a dissection or something like that. Just to go through a few other ones, substance use. So asking people about amphetamines or recent cocaine use and ischemic injury from those types of things. So I think we mentioned a lot of them. Her history was such that she had this functional bowel disorder, IBS, was on amitriptyline in the past. She lost 20 pounds in the past associated with what was thought to be this functional bowel disorder, and has since improved. She's regained the 20 pounds, but she's had episodes of abrupt weight loss. Medications-wise, she was previously on amitriptyline, and surgical history was none. When you're asking people about this too, definitely asking if they've had a history of any congenital heart disease would be important as well. So when we get to family history, this is another area where you can dive into specific family history related to cardiogenic causes. And I think we asked about on the newborn service a lot, thinking about risk for these sorts of things. Anything that we ask families that you recall?
Anyone on newborn right now and does these things? That's a great tie-in right there.
History of death in infants or young children.
Great. So sudden infant death syndrome would definitely be something to think about. Something else I think about too is was there any unexpected death later on in life, whether it's related to swimming, a car accident that is unexplained. All these sorts of things could lead you down the path of thinking that it could be something cardiogenic. Now, her history was notable for a paternal grandfather with a heart attack in his 40s, but didn't really have any of these other histories that have keying me into something necessarily cardiac right away. So typically at this point in time in a morning conference, we like to list a very long differential of all the things that could be going in based on systems. And I want to just introduce a slightly different approach, especially for something like chest pain, that I think might be helpful. And I call it a diagnostic schema. By a raise of hand, has anyone heard of these before? So a little bit, but maybe not as much. So a schema, generally speaking, is a framework that we use to organize, process, and store information. In medicine, diagnostic schema are thinking about logical ways to organize and prioritize a differential so that you can think about things in an appropriate way. And what I want to sort of introduce us to is the emergent versus the non-emergent causes of chest pain. And thinking about if you're a resident on nights, if you're someone admitting a patient from the emergency department, what you don't want to miss, right? So in my mind, there are 4 cardiac causes, 2 pulmonary causes, and 2 GI causes. And this is sort of stepping away from the case for a minute. Any age, what things don't you want to miss in a patient that's having chest discomfort in these areas?
Pulmonary embolism.
So we talked about pulmonary embolism. Great. So I think a PE would be something that I wouldn't want to miss.
Pneumothorax in the chat.
Great, pneumothorax. So that's another palm cause. You've gotten my two. Great job, great job. So both of those, especially like pneumothorax can also be benign if it's a small one, but if it is a tension pneumothorax, obviously that can compromise your cardiac perfusion. So that would be potentially urgent, emergent.
I'll say ischemia.
Okay, so ischemia. So I think, almost anyone coming into the emergency department with chest pain, that's like the first thing on a patient's mind and a family's mind is that what's going on? Agreed with you.
I mean, arrhythmia too as well.
That was another one of mine.
Yeah.
Dissection, tamponade would be, I think, the other two you're referring to.
Great. So, and I think those are pretty self-explanatory, but if you have a rupture in your aorta or if you have so much fluid around your heart that you can't pump appropriately, that would be an emergency. Can anyone think of GI causes?
Yeah, like an esophageal tear or eruption.
Great, so esophageal tear. So thinking about someone who's like vomiting really, really hard, someone who had a recent chest injury and those sorts of things. I'll tell you the other one I'm thinking about is ingestion, actually. So it's like some sort of like a wishbone down the throat. That's like more in adult medicine, right? But a button battery or a coin and those sorts of things can certainly present in that way as well. So these are like the things that I wouldn't want to miss. Briefly, we don't need to go through the differential for this, but I want to acknowledge that there's a lot of things that are also non-emergent. And the way that I like to think about them is structurally from the outside of the body, inside of the body. So in terms of my diagnostic schema, again, to step back, these are the emergent things, don't miss these. And then also just in the back of mind, have like the common things also there. So on the outside, you want to make sure you look for any sort of rash. You want to make sure that there are not any reproducible chest pain and those sorts of things. That's maybe getting into MSK, muscle strain, costochondritis, a rib fracture. Going in a little deeper, to get to the heart, you might think about myocarditis, pericarditis, heart failure. Certainly differing levels of severity for each of those things that you would want to be concerned about, but maybe not per se emergent. Lungs, pneumonia, asthma are also things that I certainly think about as we get deeper into the lung tissue and parenchyma that could cause some chest pain. In terms of GI, thinking about GERD, that was mentioned before, esophagitis. And then from psych standpoint, think about anxiety and somatic symptoms, which are oftentimes like a mimicker of cardiac chest pain. So in terms of tests that we can order, is there anything that you guys might think about as like a first tier test that we can order to help prioritize what should be on our differential?
I mean, I'm going to be a little biased here. I think you should. Yeah. I think your test is going to be determined based upon your history and your physical exam, and I don't think you should order necessarily like certain lab work until you've gotten a good physical exam on this child. But in general, I assume EKG chest X-ray is what you're referring to.
You know what?
Okay.
You're so right. I was going to get into the challenge, right? Because not all chest pain needs to be worked up. Yeah. And you're totally right that the history is like the core part of what we do for chest pain. However, if someone's showing up to the emergency department or we want to make sure that we think about maybe some of the other urgent causes or emergent causes. Not saying that we can rule them out with these tests, but sometimes these relatively low-cost tests are worth doing. So you said EKG. Can anyone think, and I'm just going to put up like the emergent causes that we talked about before, what might we be able to see, or what might we be able to learn about the emergent causes with an EKG? So we have, the ischemia, arrhythmia, dissection, tamponade. We have a PE and pneumothorax, and then esophageal rupture and esophageal impaction. Is there anything that we can figure out or cross off our list with an EKG?
Ischemia, arrhythmia, tamponade, maybe.
Okay.
Maybe.
Yeah, absolutely. So I feel like we can do all of those things. So with ischemia, what might we be looking for?
ST elevations, T-wave inversions.
Great. So ST elevations and T-wave inversions. So if you're on nights and you're looking at an EKG you got, that's probably going to be the main things you're evaluating for. The challenge with arrhythmia is that they sometimes go in and out of arrhythmias. So you might not catch it, but correct. If they're in SVT, if they're in VTAC, and might progress to a more ominous form of an arrhythmia, you can certainly catch a lot of those things. You might even look at like a QT and see if it's wildly abnormal, greater than 500. That would be very concerning. Tamponade, what were you guys thinking about? I see Keith sort of moving his finger around, which I think there's a word for that you're thinking of.
Electrical alternates.
Electrical alternates, exactly. So that is exactly what I was thinking of. It's not like always what's going on, but essentially if the heart is floating in fluid, you get like aberrant amplitudes of the EKG, which can be indicative of there being fluid around the heart. However, like tamponade more is like a clinical diagnosis too, so you're not gonna diagnose it by an EKG per se. It's more of like hemodynamic instability, having distant heart sounds, hypotension, and maybe pulsus paradoxus, which is that reduced systolic blood pressure. And I see Keith's pointing to his neck, thinking about jugular venous distension too. So lots of things. Great job, Keith. You're doing a great job. Oh, he's pressing on his liver too. This is so nice. Okay. And then PE, we also said that might be helpful too. Can anyone think of like what you might see with a PE and an EKG?
S1, Q3, T3, or whatever it is, or S1, whatever that thing is.
There's like a specific way to look for it, but like
Sophie in the chat, S1, Q3, T3.
Yeah, the most
S1Q3,
T3. It's like not super sensitive or specific.
Awesome.
The most common thing is tachycardia that you would see on an EKG.
And tachycardia.
Correct.
Yes,
Correct.
the chat says
Okay.
too.
The other thing is you might see a right bundle branch block too with like right heart strain. So there are other like small pieces you might find. Getting into chest x-ray, is there anything that we might be able to note on a chest x-ray?
I hope a pneumothorax.
Yeah.
Yeah, hopefully you can see that.
I've missed it.
For sure. Oh, bigger heart?
Yeah.
Oh, I see the hands going apart, meaning that like we're thinking about cardiomegaly too. Those sorts of things can certainly be evident. And then I think we're all thinking about like you're going to see a battery or a coin that they've swallowed. That's like an easy way to note of that. How about an echocardiogram? Do we get an echo?
Yeah, I would say no. You don't want echo's not going to be like no. I mean, you have to rule out. You have to no.
Is there typically an emergent in these situations? Is there emergent use of an echo?
I would say no.
Yeah.
I mean, for those ones, if you less of an echo, more like ED POCUS, you can assess for a tamponade. You can assess for, I mean, those things. Sure, is a like coronary anomaly seen on echo going to change my emergent management potentially, but you would be more like they would be in ICU and really looking like trash. And so no, for the most part, I mean, totally depends on the clinical picture, but based on a 20-year-old with the history that you provided, you should not get an echo.
Correct. I totally agree with you. And I think you're also pointing out that the physical exam piece is going to push you in one way or the other. So to go to the case, this was her EKG. And I know if you're listening to this as a podcast, you're not able to see it. But just thinking about the things we talked about, are we seeing any abnormalities in the EKG, like T-wave inversions? Are we seeing ST elevations? Are we seeing any form of prolonged QRS complexes? Do the QTs look about normal?
Looks fine to me.
Yeah, and the rate here, I'll just say it's over 3 big boxes, which means that it's a little bit less than 100 for the heart rate. So the heart rate's less than 100 right now. So that's also a good sign because tachycardia typically is like a heart rate. It depends on age. For a 20-year-old, they're like an adult. So over 100 is when I would be thinking more about tachycardias too. So they seem to have a normal EKG, and this was their chest x-ray, which I will say looked stone cold normal as well. Just to return to the case, of note, that history that I initially got was with grandparents in the room, and you always have them step out. So During our confidential history, she disclosed she had a fairly significant history of anxiety and a few new stressors. She was currently in college. That was all going well, but her cousin was recently diagnosed with cancer. She denied any suicidality, and I did ask about any signs of disordered eating as well, given her past history of significant weight loss, and she denied any disordered eating behaviors and no recreational drug use as well. So overall, given the constellation of symptoms and the otherwise reassuring history, there really weren't any red flag signs. I know I didn't mention it, but her exam was normal. That wasn't the pertinent part of this case. And the first tier tests that you can perform on patients were also normal. So I was fairly confident in saying at this point that this was one, not an emergent cause of chest pain, and likely a non-cardiac cause of chest pain. And when I shared this with her, you could almost see her anxiety sort of melt away. And I wanted to mention that noting that families and letting patients know that their heart is fine and not the direct cause of their chest pain is so helpful for them to effectively deal with the pain that they're having. Ultimately, she had a follow-up with her PCP. Her symptoms were improved, and she's currently being started on SSRIs and starting therapy. So hopefully the next time you encounter a patient with chest pain, you know the serious causes of chest pain are uncommon, but you still take chest pain seriously. Thanks so much, everybody.
Hey everyone, I'm back as promised and wanted to take a moment to review the main learning points from this episode. Today we learned about using a diagnostic schema when approaching a pediatric patient with chest pain by thinking about our differential in terms of emergent versus non-emergent causes of chest pain. I hope you remember the 8 emergent causes of chest pain, including 4 cardiac causes such as ischemia, arrhythmia, tamponade, and dissection, the 2 pulmonary causes such as pulmonary embolism and pneumothorax, and finally 2 GI causes, including esophageal rupture and ingestions. I hope you now appreciate the importance of a good history when narrowing down your differential when you have a patient with chest pain. And remember to ask patients and families about red flag symptoms as part of the history, such as 1, exertional chest pain, 2, syncope without prodrome, and 3, symptoms that are rapidly on and off. When it comes to testing, remember the basic first-tier workup for chest pain to help prioritize your differential, including an EKG and chest x-ray. And make sure to reserve echocardiograms for select situations with a concerning history or abnormal first-tier tests. Also be mindful to do an appropriate workup prior to labeling a patient with anxiety. Finally, this is not mentioned in particular, but know that cardiac causes are an unlikely cause of pediatric chest pain, which truly only accounts for approximately 0.2 to 1% of otherwise healthy children, but often is what patients and families are most concerned about. I hope this episode will give you more confidence the next time you find yourself caring for a child with chest pain. I want to thank Dr. Emily Jacobson and Dr. Jody Ehrman for fact-checking this episode, and Keats and Judah for joining me up in front. Now, before you go, I have an ask for you. If you're enjoying this content, it would really mean a lot if you would review First Pediatrics on your favorite podcast platform. Also, there's so many ways to spread the word these days, but consider sharing an episode with a colleague today, post it on social media, or any other way you like to share content. I hope to grow this podcast and can't do it without you. Thanks as always for joining us, and I look forward to seeing you next time on First Pediatrics.